So we have different studies and different bits that we're interested in. Initially, we started as ECMO card. We rely, and the rationale, just to those that are listening, the rationale behind calling it ECMO card was, it started from Asia Pacific ECMO Society. We were very fortunate to have Bob Bartlett as our chair of the steering committee, who's turned up every single meeting, day or night, whether he's in the hospital or at the beach or at his beach shack. But we also looked at other things. But one of the key questions I spoke to my friend and colleague Eddie Fan about was, look, at the start of this pandemic, we don't know who to put in a ventilator, we don't know who to put in ECMO, and we don't know when to switch them across. There weren't enough ventilators, there weren't enough ECMO machines. The question was, is there a benefit? Because the early data said ECMO didn't work. So is there a benefit? If there's a benefit, who should get ECMO? And when do we switch them on to ECMO? And that was a question I posed to Eddie, who's incredibly brilliant and incredibly humble. And I said, you will do this better than we will, and not just better than us, but Eddie found someone even better than Eddie, and he found Martin Urner, who is going to present. This is part of his PhD, I believe. This is an incredibly important part of our study, and they took this task on. Thanks to Toronto, they took this task on and did an amazing job. So Martin and Eddie, thanks for taking the task on. Dan Brody at the European ELSO meeting said this recently, 40 years of ECMO studies, and this, despite being unable to do a randomized controlled study, this was one of the most important outcomes that we've got, and one of the most definitive outcomes that we got, despite an RCT. So we can do an amazing amount of things once we get the power of 20,000 data points. And as Dan pointed out, it's amazing what we can do with rigorously collected observational data. But Martin, thank you for a great piece of work. We're going to pass you the microphone, and we'd love you to tell us about the study that you've done. Thank you, Martin.
Thank you so much for allowing me to present this most recent piece of research work from our consortium on the treatment effectiveness of ECMO therapy in patients with acute respiratory failure from COVID-19. John already mentioned early reports on the use of ECMO therapy in patients with COVID-19 were discouraging and made clinicians hesitant. Mortality rates in very, very early meta-analysis of up to 94%. And ECMO is also a very resource-intensive therapy. However, these earlier reports and studies lacked of adequate controls and often had methodological issues. And there is an additional challenging factor, which is illustrated here in the slide. You see the results of Barbaro and colleagues from the ELSO registry. They described the outcomes of 4,812 COVID-19 patients recorded in the ELSO registry, and illustrated in the graph, you see that the mortality range from 37 to 59%. And interestingly, we see that there is a signal that the mortality after ECMO therapy for patients with COVID-19 worsened over the course of the pandemic. You see here the blue part around closer to 30% early adopting centers, and then closer to 60% late adopting centers, and the average is somewhere between 40 and 50%. And now with mortality rates up to almost 60%, conditional on the receipt of ECMO therapy, one might wonder whether we should provide ECMO therapy to our patients. And our evidence for the use of ECMO therapy to support COVID-19 patients was mainly based on the results from the EOLIA trial. The EOLIA trial demonstrated in 249 patients that ECMO therapy reduced 60-day mortality by about 11%. This difference was statistically not significant. Relative risk was 0.76. However, a Bayesian reanalysis published in JAMA demonstrated that the posterior probability for a benefit of ECMO therapy is extremely high, even with the most skeptical prior beliefs about the effectiveness of ECMO therapy. I mentioned this importantly because the Eolia trial had to deal with several challenges. Enrollment was difficult. Many patients could not be enrolled because they were already placed on ECMO before becoming eligible for the Eolia trial. There were also challenges with a substantial number of crossovers. It took a long time, it took years to complete the trial, and this highlights how difficult it is to measure comparative effectiveness of such a complex intervention like ECMO therapy in the controlled setting of a randomized controlled trial. The analysis of observational data might provide an alternative way to measure the comparative effectiveness of different interventions under real-world conditions. The most famous example is probably the mRNA vaccine effectiveness study published in New England Journal of Medicine, where they investigated the effectiveness in a nationwide mass vaccination setting in Israel. In this project of the COVID-19 Critical Care Consortium, we were asking, what is the effect on hospital mortality of a treatment with ECMO if the PF ratio is less than 80 millimeters of mercury as compared to conventional mechanical ventilation without the use of ECMO in patients with acute respiratory failure from COVID? To answer this research question, we used data from the consortium recorded between January 2020 and August 2021 to emulate a pragmatic clinical trial using the registry data. We included all adult patients admitted for mechanical ventilation to the ICU with clinically suspected or confirmed COVID-19 infection. Our primary outcome was hospital mortality up to 60 days, and we considered hospital discharge alive as a competing event, precluding the occurrence of the primary outcome. You see here the two treatment strategies, ECMO if the PF ratio dropped below 80 millimeters of mercury versus conventional mechanical ventilation. And we compared these treatment strategies and were interested in adherence adjusted estimates because they reflect the causal effect. So it's like a per protocol analysis of a randomized controlled trial. And these slides illustrates how we emulated this target trial using marginal structural models with inverse probability weighting. Here on the left side, in a first step, we created clone copies of each patient at baseline and assigned one clone to each of the two treatment strategies. Why did we do that? It's registry data, so we can no longer randomize the patients, but we somehow have to create exchangeability at baseline. And this approach of cloning patients, so patient one clone was assigned to ECMO therapy and one clone was assigned to mechanical ventilation. This is statistically very efficient, and clones are by design identical at baseline. So it creates exchangeability at baseline and is similar to perfect randomization. In a second step, illustrated on the left side, we followed these patient clones over time and artificially censored clone copies that were non-adherent to the initially assigned treatment strategy. You see that here for patient number two. Patient number two, and the clone that was assigned to ECMO therapy was perfectly adherent. On day 4, met the threshold, was placed on ECMO. We continued to follow. Unfortunately, the patient later died. However, the clone that was assigned to the mechanical ventilation arm was not adherent because day 1 is okay, day 2 is okay, day 3 is okay, but here a crossover happened. The patient was placed on ECMO. So we had to adjust for this non-adherence or deal with this non-adherence, and we artificially censored the patient. And this artificial censoring, of course, will introduce selection bias in the analysis because this artificial censoring is associated with prognosis. Therefore, in a third step, here illustrated as weighted analysis, we used inverse probability weighting to adjust for this selection bias due to the artificial censoring. And in this weighted analysis, we compared what would have happened had all patients received our intervention strategy versus had all patients received the control treatment. And this corresponds to the causal effect of ECMO therapy in our analysis. You see these little squares, P1, P2, P3, P4, and this is how we calculated these inverse probability weights. And the weights were computed from the estimated daily cumulative probability of remaining adherent to the initially assigned treatment strategy. So each day we computed this probability and we estimated these probabilities based on clinical markers like the PF ratio and other factors that clinicians would use to decide whether a patient should be placed on ECMO or not. The final analysis comprised a total of 7,345 patients. 844 patients were treated with ECMO therapy at any time point during follow-up. And you also see a map of the countries that contributed data to the analysis here on the right side. In table 1, in the baseline characteristics recorded at the time point of ICU admission, we see that a broad population of patients with COVID-19 was included. The median PF ratio was about 130 millimeters of mercury. And of note, a relatively small number of patients underwent prone position or received neuromuscular blockage agents. This is likely because not everyone qualified for these interventions. Median PF ratio is 130. However, it might also be a sign or related to the fact that some medical centers were probably overwhelmed with the sheer numbers of patients. Also, only about 40% of the patients had received corticosteroids, which reflects that the registry data was collected over the course of the pandemic with new evidence about new treatments evolving over time. These are the results of the primary analysis. In the primary analysis, we found that ECMO therapy reduced hospital mortality up to 60 days by about 7% with a risk ratio of 0.78. This is illustrated here in the upper panel, yellow, the intervention strategy where ECMO therapy was available, and purple, conventional mechanical ventilation. And in the lower panel here, you see that part of the total effect of ECMO therapy on mortality was partially mediated by the occurrence of the competing event, meaning that patients after ECMO therapy were more likely to be discharged alive. In secondary analyses, we found that the treatment effectiveness of ECMO therapy decreased with increasing age. You'll see that on the left panel that the risk ratio comes closer to the no effect line with increasing age. Interestingly, different comorbidities such as hypertension, obesity, or diabetes did not substantially influence the treatment effectiveness of ECMO therapy. However, patients with obesity, they have a substantially higher baseline hazard of death compared to patients without any comorbidities. So it's very important to interpret these risk ratios in the context of the baseline hazard of death that is associated with different comorbidities. We know that especially very, very obese patients it's difficult to do rehabilitation, and these are factors that are not captured by our outcome, and this minus 11% risk difference should not let us forget that that these patients have a substantially higher baseline hazard, and that is important to include in your decision-making process. In a further secondary analysis, we found that prolonged preceding duration of mechanical ventilation reduced the treatment effectiveness of ECMO therapy. You'll see that it's highly effective if initiated early, and later the risk ratios come closer to the no effect line. In a further secondary analysis, we also investigated if ECMO therapy reduces mortality if initiated with different thresholds for the PF ratio. And in the upper panel, you see that there seems to be a signal for benefit in patients with a PF ratio between 80 and 120 millimeters of mercury if we initiate ECMO with these, in this PF ratio range. And in the lower panel illustrated, however, the initiation of ECMO therapy if the PF ratio was greater or equal than 120 millimeters of mercury was no longer associated with a reduction in mortality up to 60 days. Finally, we investigated if ECMO therapy should be used to limit potentially harmful exposures to higher intensities of mechanical ventilation, as measured here by exposure to static driving pressure. Initiation of ECMO therapy was beneficial if exposure to higher static driving pressure levels could be prevented. The optimal threshold for the upper limit of driving pressure seems to be around 15 centimeters of water, while more strict or more lax threshold, you see that stricter thresholds is limiting below or equal than 12. Lax thresholds are limiting limiting equal or below 20 centimeters of water. And these more strict or more lax thresholds were less effective in reducing mortality. So the sweet spot is probably somewhere around 15. Summary of our results before I briefly compare that with other approaches. In this registry-based cohort study of 7,345 patients with COVID-19 associated acute respiratory failure, we found that treatment with ECMO, if the PF ratio dropped below 80 millimeters of mercury, reduced hospital mortality by about 7% compared to treatment with conventional mechanical ventilation. Risk ratio 0.78, very similar to the risk ratio of the EOLIA trial. In secondary analyses, we found that patients benefit the most from ECMO therapy if they are younger, if they have more profound hypoxemic respiratory failure, if we can prevent exposure to higher intensities of mechanical ventilation as measured by static driving pressure, and if ECMO is initiated early in the course of mechanical ventilation. Of course, it's observational data. This registry was collected during the strain of the pandemic. So there are limitations, potential residual confounding, limitations in the modeling of such a complex intervention like ECMO therapy, missing data. Our way to deal with missing data might have influenced the results. We did many sensitivity analyses and our results were very robust. And I will now briefly compare this to two other studies in the field and see how our results compare to these other approaches to answer a similar research question. So in this study presented here by Shahzad Shaifi and colleagues published in Intensive Care Medicine, the authors compared treatment with ECMO versus conventional mechanical ventilation in 1,297 mechanically ventilated patients from the United States with a PF ratio of less than 100 millimeters of mercury. A total of 130 patients received ECMO therapy during follow-up, and despite using a very different statistical analysis approach, the authors measured an adjusted hazard ratio for mortality of about 0.55, suggesting that ECMO therapy lowers mortality up to 60 days, and this is very similar to the findings of our study. This is the most recent study from investigator David Hajaj and Anna Gomp, a study from France, Belgium, and Switzerland, and David and colleagues investigated 4,244 patients that met the EOLIA criteria. A total of 269 patients received ECMO therapy. And in the primary analysis, the authors only found a small risk reduction of about 2%. However, in a subgroup analysis that was restricted to patients treated in high volume centers, the survival was 78% for patients treated with ECMO versus 64% for patients treated with conventional mechanical ventilations. So it's also supporting the findings that ECMO therapy is beneficial if provided to well-selected patients treated in high volume centers. So I tried to make a table to illustrate the differences in the analysis approaches. So our study answers a different causal question from the studies of Shaefi and Hajaj. Shaefi and Hajaj used the sequential trials approach to answer the research questions. In both studies, mechanically ventilated patients became eligible for their target trials if they had COVID-19 and met a predefined PF ratio threshold below 80 or below 100 millimeters of mercury. And this contrasts with our study using consortium data, because patients became eligible if they were admitted to ICU for mechanical ventilation. So the PF ratio did not matter for eligibility. So a different population has been investigated in these two approaches. And also the time point zero of treatment allocation, time point zero is different between these studies. The time zero of the analysis was at the time of decision whether to perform ECMO therapy in the approach using sequential trials. So the coin flip and randomization happened at the moment when the clinician team had to decide, should we place the patient on ECMO or not? While in our BMJ paper, the coin flip happened at the time point of admission to ICU. At this time point, randomization happened and patients were assigned to either treatment or intervention or control. So that means that also the interventions are not exactly the same. In the sequential trials approach, ECMO therapy was provided to all patients in the intervention group, and all patients of the control group received conventional mechanical ventilation. In our study, the intervention group consisted from usual care, and patients received ECMO therapy if needed, if the PF ratio dropped below 80 millimeters of mercury. And in the control group, patients received usual care, but there was no option to get ECMO therapy. And the analysis approach in the sequential trial studies is ECMO initiators were matched to non-ECMO initiators. So on each day of mechanical ventilation. And then the outcomes were compared. So day one, you have initiators, non-initiators, you compare the outcome, you move on to day two, you compare non-initiators to initiators of ECMO therapy, and so on up to day 7. And then you have these estimates from different comparisons, and you pool these estimates from these nested comparisons to create the summary estimate. That's how they did that for the sequential trials approach. In our approach, and I briefly explained that with the graph before, we use this cloning, artificial censoring for non-adherence, and inverse probability weighting and the weighted analysis to estimate the causal effect of our intervention as compared to the control. And so what I tried to highlight with this table is the studies used a different approach. The population was slightly different. Time point zero, the time point of randomization was different. And also the comparison, the causal question was not the same. However, as a matter of fact, the results from all these studies were similar and clearly showed a benefit of ECMO therapy. And this highly strengthens our confidence that ECMO therapy is effective to treat well-selected patients with COVID-19 associated acute respiratory failure. This concludes my talk. We could go on about target trials for a long time, but I would like to thank Eddie Fan, Adrian Barnett, John Fraser, Gianluigi Libassi, and of course all the members and contributors of the consortium. I really hope that this talk highlighted how unique the consortium data is, and that it would not have been possible to answer the research question without all your help and support. So thank you so much.
Martin, a fantastic presentation, and congratulations on a huge piece of work. Look, you've managed to do an amazing amount of work. The data that the group has provided is, of course, huge. But what you've managed to do, I think, with these data is fantastic. You managed to get these data, get them erect, and get them standing up straight in line. I'm going to ask Adrian Barnett to see how it was the mechanism, the way that you penetrated this huge amount of data. Adrian, to those that don't know, has been key to Martin's study and to the whole consortium. And just to talk about the methodology, Adrian, and how valid it is, it's an amazing study. Adrian Barnett, please.
Oh yeah, thanks, Martin and John. Yeah, just to say, I mean, the thing that I really like about this is when I look at a lot of hospital data, and you see this patient cohort come in and they change really rapidly from day to day. So, the people who exit in the first 3 days are very different to those who stay longer. So I really like, that one of the things Martin analysis does, starting from admission and randomizing from admission. But then you look at every day and you sense the people who leave, or, from every day, we're only comparing a sort of comparable cohort. And if somebody starts on ECMO on day 3, that's different to somebody starting on ECMO on day 5, and they're compared to similar patients who also made it to day 5 without ECMO. So yeah, look, that's the sort of sophistication, and the target trials. I think with this sort of observational data, it's been the best use I think I've seen so far of this data, and really interesting results. So well done, mate.